Hi everybody, this is Dr. Peters, and we're going to talk about peripheral arterial disease, or peripheral vascular disease is another term. Let me see if I can get the screen a little bit bigger. Hold on. Actually, I'm going to move this up. Maybe that'll work. Okay. All right, so we must not forget about peripheral arterial disease. Remember, we have arteries running through our body, so we commonly think of heart disease and stroke with people with risk factors such as diabetes and renal disease, etc. But we can't forget that we have blood vessels everywhere, arteries and veins, and so we can have arterial disease also with plaque buildup. So this is the latest guidelines, and so I'm going to go through this slide set. I'm going to not read every single slide word by word because I know you guys can read, but I want you to have an idea exactly what evidence-based guidelines are out there for this. Okay, so this is a really important slide to understand what the strength of recommendation, and the level of evidence or the quality of evidence. So you can always scroll back to the screen or look back at the screen after you print out your slides. But class 1 is strong evidence, and level A is your the best studies, the randomized controlled trial studies from more than one. Level BR is your moderate evidence from one or more randomized controlled trials. BNR is moderate evidence, and then you start getting down to more observational studies, meta-analyses, and more of like clinical experience. Okay, so just so you have an idea. And then class 1, 2, 2B, 3, and 3 harm is down here. The risk versus, we're talking about risk versus benefit. Does the benefit, is the benefit greater than the risk or the opposite? All right, so we're going to go on. So we're going to talk about assessment for peripheral arterial disease. You're going to see a lot of abbreviations, so I'll try to remember to say what they are. Diagnostic testing, screening, medical therapy, exercise, as well as a couple other things. All right, so let's go to history and physical exam. And so a lot of these are going to look like this, but I want to show you this because it's really important the way we screen and what the evidence is out there. Does it mean that everybody uses evidence-based? No, it's written in pencil or erasable pen, although we should follow it because it is by multiple randomized controlled trials if you have that higher quality of evidence. So as we see here, our level of evidence is pretty good. So BNR, let's go back to that. Your BNR is your moderate level evidence, and class 1 is strong. So patients at increased risk for peripheral arterial disease should have a comprehensive medical history. You want to ask about leg symptoms, claudication, do they get cramping when they're walking, or other walking impairment? Are they having ischemic rest pain, non-healing wounds? So look at that type of stuff. Also, palpate their lower extremity pulses, auscultate femoral bruits, inspection of the legs and feet. And then also they should undergo blood pressure measurement in both arms at least once during the initial assessment. So these are all your history and your physical exam in a nutshell. What are risk factors though? If you're over age 65 or even younger and have other issues, smoking is really huge. Hyperlipidemia, hypertension, diabetes. Is there a family history? What if you're less than 50 and you have diabetes and another risk factor such as you smoke? So you're at increased risk, so we need to screen all of these populations here. Also, we can't forget about other vascular beds such as coronary, carotid, subclavian, renal, mesenteric artery, stenosis, AAA. Think of my father who was a smoker for 55 years. He had vascular disease basically everywhere in his body. So he's had carotid endarterectomies, he's had a stroke before, he's had coronary artery disease without an MI, he's had stents put in his iliac artery in both of them. He needed a FEMPOP bypass, but he was too high risk because he had emphysema end stage. He ended up dying of mesenteric artery stenosis. So it was really sad, but basically his arteries were just completely a mess basically, and it was very much a familial thing too, but smoking really did speed things up. So what are some suggested findings? Claudication, remember the cramping when they're walking? Are they having issues when they're sitting down or at rest, which is the ischemic rest pain? Are they having a hard time where they can't walk very far or their legs cramp up? And again, we're going to check for bruits, and these are all the things that are suggested before in the couple slides before in the guidelines. All right, so how are we going to screen for this? Or say you do all of these and you suspect or they're having symptoms, what are you going to do? You're going to order a ankle brachial index for claudication or critical limb ischemia, which is more of a dangerous situation. What is an ABI? What's an ankle brachial index for diagnosing? So it's actually, you measure the blood pressure in the ankles as well as the upper arms, and then you compare them. And so there's a ratio that comes up. It's a ratio, it's a calculation. And so lower blood pressure in the legs suggests that you have some blocked arteries, that you can have some peripheral arterial disease. So the normal here, as you can see, is normal is 1 to 1.40. Abnormal is less than or equal to 0.90, and then you have your borderline and non-compressible, which is just more of an inconclusive. So in patients with H&P findings suggested of it, you need to get an ABI. So you order ankle brachial index. And usually that's done in the cardiovascular services area. It's a pretty quick exam. You actually could do it in your office. You can do a modified one. There's a lot of, if you just Google how to do an ankle brachial index, it can show you. You can find stuff with that. Okay, so this gives you the category 1. So this is pretty good. And these are pretty good suggestions, although this says no benefit. But again, you would just order an ankle brachial index and understand what the results mean. So what is TBI? That's toe brachial index. So that usually is next after you suspect arterial disease. If this ABI is greater than 1.40, patients with exertional non-joint related leg symptoms with normal or borderline should undergo exercise treadmill ABI testing. So then they go on the treadmill to see what their blood flow, if there's getting good blood flow to the lower extremities. So that would be next. In patients with already peripheral arterial disease and abnormal, you can do the ABI testing to check how their functional status is. But sometimes if they're functioning fine, they may be having some collateral circulation, then maybe they won't need an intervention. Also, these are some other recommendations. So in patients with normal or borderline ankle brachial index, if they have wounds that are not healing or gangrene, oops, what happened there? That's kind of strange. Hold on. From current slide. Okay. It's reasonable to diagnose critical limb ischemia by using the toe brachial index with the waveforms. That's just part of the testing that they're doing. And then with patients with peripheral arterial disease with an abnormal ABI, or they can't compress the arteries, and they have non-healing wounds, so that's the key thing here, non-healing wounds, they have to go further with the TBI to make sure to see what local perfusion is to their toes, because maybe they need an amputation, but it just depends. So here's a nice little algorithm we all like, or at least most of us like algorithms. But if so, diagnostic testing for suspected PAD. So you did your history, your physical, and they're in the risk factors, and they're having symptoms. Maybe they're just having risk. They have high risk factors. This brings you right down the line on what to do. So if it's normal and they're having leg symptoms still, you want to maybe search for an alternative diagnosis, or they're still having it, you want to do an exercise ankle brachial index, because maybe that'll tell you a little bit more. If that's normal, again, you're going to search for alternative diagnosis, but if that's abnormal, You're going to look into other therapy, lifestyle, talk about revascularization. So they would be going to a vascular surgeon. I think it's important for all of you to know in primary care because you're going to run into things like that. And so you really need to know the algorithm for what you're going to do next, what should you do next, even though you're not going to be obviously involved in revascularization, but you should know about that. So then it just goes right down to here. Sometimes you have to end up getting an ultrasound or an angiogram, etc. And it tells you what to do for normal ABIs, and it's normal, so that's good. And so just so you know, do not perform any invasive or non-invasive assessments for asymptomatic patients. So they really haven't found any benefit if everything is normal. You don't need to go further with that unless they're still having symptoms. So this is diagnostic testing for suspected critical limb ischemia. You know, that person that comes in and has non-healing wounds, or they have like this cold toe, or you have pain at rest. So if they don't have that, again, you're going to search for the alternative diagnosis. But if the ankle brachial index, if it's normal, abnormal, you're going to do some additional perfusion studies. And this is for suspected chronic limb ischemia, which means a wound or gangrene. That's when you're going to go further with that. So you can just read this on the side here. It tells you exactly what the mnemonics mean here. The CTA, the MRI, oxygen pressure, and toe brachial index, and what to do. So this is imaging for anatomic assessment, and it's recommended to get an ultrasound, a CTA, MRA of the lower extremities to diagnose the location, the exact location and severity of stenosis. So everything's abnormal. Now we got to go a little bit further to determine, do we need revascularization or do we need a stent? Invasive angiography is also another consideration. Again, you're going to be referred to vascular surgeons by this point, but just so you know that this stuff is what is done. You don't have to know this part for testing purposes, but you do need to know your steps and when you would refer. And obviously, if people are having lifestyle limiting claudication, that's definitely someone that you would consider revascularization on. But invasive and non-invasive angiography, such as your CTA and MRI, should not be performed with asymptomatic PAD. So just remember that if they're not having symptoms, then there's no reason to get a screening for that. If someone's diabetic, that's a risk factor, so you could get a screening, but it would only be one screening. And if everything's normal, you're just going to do your physical assessment every time you see them. You don't get routine screenings for that. All right, so this is for things in other beds. So what are other vascular beds? Other vascular beds are your renal arteries, your coronary arteries, your abdominal aorta. So if you already have PAD and symptomatic PAD, peripheral arterial disease, it is reasonable to get a AAA screening, just because remember, we can have blockages anywhere in our body, and if we have arterial disease in our extremities, we could very well likely have them in other parts of our arteries. So that includes coronary, carotid, and renal arteries. So prevalence of it is higher with people with PAD than those without PAD, which would make sense. So justification for screening and other arterial beds is if revascularization results in a reduced risk of MI, stroke, or death. It's never been really shown. So again, if you're having already symptoms, then it's reasonable to get that. So no evidence to demonstrate screening in all patients for asymptomatic atherosclerosis improves clinical outcome. But remember, those are guidelines, so it doesn't mean that always happens in real life. So, I tend to lean more on the cautious side. So obviously they'll be with a vascular surgeon if they have PAD. But if you suspect something, and Medicare patients get a one-time AAA screening anyways. So what are we going to do with these people? So I always refer to vascular surgeon, but sometimes But in primary care, we still have to see what the risk factors are and what are we going to put these patients on. You can leave it to the vascular surgeon to initiate antiplatelet therapy, or you can in primary care once you have a consultation with them. So what's the highest recommendation? With aspirin or clopidogrel, your Plavix, is recommended to reduce MI, stroke, and vascular death with this is symptomatic peripheral arterial disease. Asymptomatic, all right, this is in your ankle brachial index results. It's reasonable, so it's something to consider. Those with borderline, we're not really sure. So, sometimes you'll see patients on it and sometimes you won't. You have to look at their risk factors. Are they really elderly and at increased risk for falls and that kind of thing? So maybe they're not a good candidate to be putting on blood thinners. The effectiveness of dual antiplatelet therapy, that's aspirin and clopidogrel, is not well established. So we're seeing a lot of that stuff go away. There's been some newer studies showing that really they don't need to be on both. Dual antiplatelet therapy may be reasonable to reduce the risk of limb-related events in patients with symptomatic PAD after revascularization. So, but again, that's up to the vascular surgeon and their risk factors. Treatment of statin medications indicated for all patients. So remember that. So if you see this, make sure they're on a statin if they have arterial disease. And even with diabetes, we really should be on a statin. Antihypertensive agents. They should be administered to patients with hypertension and PAD to reduce the risk. The use of ARBs, ACEs, angiotensin converting enzyme inhibitors, or ARBs can be effective to reduce the risk of ischemic events. So ACEs or ARBs are recommended because remember, these two are like brother and sister, so you only need to do one, not the other. ACE inhibitors, your quinapril, lisinopril, the ILs, and the ARBs are valsartan, like AN is at the end, or ENE, and no, they're valsartan, that kind of thing. Amlodipine, that's calcium channel blocker. We would not use that first. We would go to these first. And then the usefulness of anticoagulation to improve patency after a prosthetic bypass is really uncertain, but anticoagulation should not be used to reduce the risk of ischemic events. So really they should already have stuff, revascularization already done, or we know that they have issues already. Smoking cessation is absolutely huge. It's very critical. The earlier that they quit smoking, obviously, the better. They should be advised at every visit. They should be counseled at every visit. They should have a plan at every visit. And again, secondhand smoke is not good either, and different environments. Diabetes, glycemic control is very important. So as you can see, as I'm going through these now, I'm going through all the risk factors and how important it is that they have their blood sugar under good control. And it really can reduce outcomes. These are some other medical therapies that can be used to help people that perhaps are still having symptoms. It's so chronic. Like I think of my father, for example. He's had stents. He can't have a bypass, but yet he can't walk very far because his legs start cramping up. He can't handle it. So you could put him on silostazol, although my dad was never put on that, but that's an idea. People in the past have been put on pentoxifylline, also this chelation therapy, but there's really no benefit to it. Doesn't mean you won't see it out there, but we know that evidence shows that there's really not any benefit. Also, no benefit for any vitamin supplementation to lower homocysteine levels. It's recommended they have an annual flu vaccination. And exercise is really important also. A supervised exercise program is recommended because we want to increase quality of life, try to reduce leg symptoms. So whether it's at home, it's better if it's a supervised so they get on a good regimen. And this explains here when they go. And obviously everybody gets a specific plan when they go in. And sometimes people will do it at home. This has to do with patients with PAD and diabetes. We know, as we just talked about diabetes, how self-foot examination is very important. We don't want amputation. We don't want to miss any feet infections. And don't forget about athlete's foot, because that can start it right away. And these are just some of the multiple interdisciplinary teams that we would have to refer out to people with peripheral arterial disease. It's quite a bit. And then what's the last choice? Well, last option's amputation, obviously, but right before that's the revascularization, whether they put a stent in or they do a bypass surgery for that. And this is the diagnosis and management. So someone comes in with a painful leg, you suspect the acute limb ischemia, you're going to do your clinical evaluation, you're going to check your the motor sensory, Dopplers. If they have inaudible and they have complete loss, that's usually amputation. So that's over here in this section. If you can hear it and they have a viable limb, everything seems pretty normal. You want urgent revascularization and anticoagulation. But say here it's an audible arterial, but audible venous motor function assessment. If it's intact, if they're marginally threatened, you want to see down here at the bottom, it says emergency revascularization and anticoagulation. And in category 2B, immediately threatened, it's also revascularization and anticoagulation. So it's the same thing with that. All right, and that is it. Oops, sorry about this, guys. I can't get it shut off. Hold on, I gotta get there. There we go. All right, that's